Good evening, everybody. So today we are meeting for the 32 times, basically, already. And today we have our guest, Dr. Rahim Dhalla, who is going to talk about cannabis and pharmacist advice. But before he introduces himself, I will just tell you that we are available on 3 different channels, on the YouTube, on the Facebook, and also on the Pharmacy College website. So please enjoy this evening with us today. Hopefully you will find, as always, a great boost of information. Thank you very much. Rahim, thank you very much for accepting the invitation for our meeting today. So please introduce yourself.
Thank you so much for having me. My name is Rahim. I am a pharmacist here in Ottawa, Canada, and I have started my own cannabis pharmacy practice. So it is a regular dispensing pharmacy, and we do specialize in medical cannabis. And we are one of the first in Canada to actually have a medical sales license. So we are dispensing cannabis out of our pharmacy.
Excellent.
So thank you. Yeah, again, thank you so much for having me.
It's actually very good because we are running under the supervision of Regis Vaillancourt, Dr. Regis Vaillancourt from Canada, the Cannabis Project, and it's actually a global project. Rahim is responsible for this project in Canada. I'm responsible for the project here in Poland, and we are just actually trying to check the attitudes towards use of cannabis of Polish pharmacists. And also, we are checking how the actually patients are responding to the marijuana use or cannabis use during the COVID-19. So hopefully, we are going to have a great piece of research together internationally as well.
Absolutely.
So, thank you very much for having us here today. And I think we should just start our presentation. And obviously, you can always ask and drop your questions on the chat. We'll be just able to respond it once you just ask us. Thank you.
For sure.
We can start the presentation.
So we'll jump right into it. Like I said, my name is Rahim. I'm a pharmacist here, and we've started one of the first cannabis specialty pharmacies in Canada. And you know, as we go through the presentation, we're going to want to touch on like what's our main role, like why should we be involved? Obviously, identify the key players of the endocannabinoid system, and this is important because we need to understand how medication works, and that's what we do. We're pharmacists. We understand pharmacology. We understand the mechanism of action. If you understand that, you understand how the drug works and maybe its therapeutic applications. I'm going to review some methods of consumption, metabolism, drug interactions, some adverse effects, and obviously examine some practical considerations within the community pharmacy setting. This is just a couple photos of my pharmacy right now. The dispensary in the top left corner right there, where we store all the medications, and the compounding lab is in the back.
The presentation on the screen, because I think it's not presenting.
It's not presenting?
No.
Let me share my screen. Can you see it?
Not yet.
Is it good?
I cannot see it yet. Only from tab. Okay, we are sorry for this. It sometimes happens, unfortunately.
Are you able to see my screen?
Not yet.
Okay,
One second.
Chrome tab. So I'm in the.
What do you say if I share it from my screen and you will just tell me next slide? Because I can do it.
Yeah, sure.
Yeah, let's do it. And you will tell me if you can see the presentation. Can you see it?
Nope. Oh, there we go.
It is? Yeah, it's fine?
Yep.
Okay.
Perfect. Yeah, so we're reviewing explaining the role of the pharmacist. I think this is a very important topic because in the global world of cannabis, I feel like there's not much healthcare intervention. And as we are the drug experts, we know medications, we should definitely be talking with our patients in regards to cannabis and how to consume, how to dose, and watching out for drug interactions. And this is where we'll be able to identify some of the drug interactions. We'll go over the endocannabinoid system, review the metabolism, and really just kind of touch on what things that I'm doing in my practice right now, how I'm speaking to my patients, and really the top common ailments that we're seeing. Next slide, please. So as pharmacists, we should know this already, right? We are the most accessible healthcare professional. When patients have any type of issue, they are coming to the pharmacy asking for our advice, and we are counseling them on over-the-counter products, medications, drug interactions, dosing. Go far enough to say that we do know more about medications than doctors do. Doctors are specific for diagnosis and therapeutic, but we are there to guide them as well as guide patients on what drugs are appropriate for their condition. We're also compounders, right? We can make drugs that do not exist on the market. We can really formulate to patients. And I think that's a big component here, especially in cannabis, where it's a very individualized medication. And that even leads to harm reduction. Well, why give someone an oral capsule or oral dosage form when you can actually use it topically and have less systemic side effects? Again, this also plays into cannabis. That we should be using a harm reduction strategy when discussing cannabis therapy. Getting some patients off of smoking, going to potentially a vaporizer, or going towards an oral dosage form, or a topical, or a suppository, or a transdermal. So there's a lot of conversation to have with patients about the best dosage form for them. And I think a big part of my practice that I'm starting to notice when we first started Hybrid Farm was deprescribing, which is reduction of unneeded or unwanted pharmaceutical medications. We know many patients are on a multitude of medications, and by starting on cannabis, it can help lower the dosage of other medications or even come off them. We've had multiple patients reduce from 6 to 10 opioids pills per day and drop down to 1 or even none. So there is a big opioid sparing effect. There is a big pill sparing effect when using medical cannabis, and I think that's a really important part, which also ties in to harm reduction. Next slide. Like in Canada, these are my stats from Canada. At least about 25% of patients over the age of 65 are using 10 or more medications. So we have what we call a drug problem here, right? We are using way too many medications, and when you start using too many medications, you run into polypharmacy, you run into more drug interactions, drug disease interactions, prescribing cascades, more side effects, and this can just lead to negative outcomes. And that's what we're finding with the introduction of medical cannabis into these patients' regimens. We are able to help reduce them or help reduce the escalation of some of these medications. Next slide, please. So in order to understand really how cannabis works, we have to understand what's involved, what's the mechanism, why is this important? How we were never taught this in pharmacy school or medical school. And because when you look at it, it's one of the biggest receptor systems in our body. It is found throughout nature. All mammals, birds, reptiles, fish, amphibians, we all carry what we call an endocannabinoid system. And this quote was from a study that I found, Justin Sinclair in Australia. I like this quote because it just really sums up the endocannabinoid system very well. And it's a vital physiological neuromodulatory system involved in the regulation of homeostasis. So really what that means is it's a homeostatic regulator, and it's involved in the protection of our systems. Next slide, please. So the way it functions is that if we have any offending agents, or let's say seizure disorder or chronic pain or anxiety, our endocannabinoid system will sense this, and it will release anandamide and 2-AG, which are endogenous cannabinoids, from the postsynapse, and then they will travel up to the presynapse and shut the offending agent down. So it is a modulatory effect. Just remember, these type of endocannabinoids, anandamide and 2-AG, they are not stored in vesicles like serotonin, norepinephrine, dopamine. These are made on demand. They are synthesized on demand. And I think that type of mechanism and that type of signaling system is very protective in nature. And I think this is why because this is found all over our body in so many different regions of our tissues and organs and cells, that plays into a lot of disease state as well. Next slide, please. So part of the endocannabinoid system, it's made up of receptors, ligands, and enzymes. The two main, or I say three main receptors involved are, the first one is a Cb1 receptor. This is the most abundant G-coupled protein receptor in our body, and it's mainly found in the central nervous system. Interestingly enough, it is not found in the brainstem, and this is why this is a safer therapeutic option versus opioids, in which opioids are found in the brainstem. And obviously we should know that too much opioid dosage, too much usage can cause a respiratory depression leading to death. This is not found in cannabis and therefore can be much safer to use. Things that bind to the Cb1 receptor, anandamide, 2-AG, you have THC, Cbn, which is actually an oxidative byproduct of THC, and many other cannabinoids may have an interaction with the Cb1 receptor. When you activate it, it does do a whole slew of different things. It can reduce your cyclic AMP. It can stimulate the mitogen activated protein, regulates the neurotransmission of dopamine, norepinephrine, serotonin, GABA, glutamate. And interestingly, it blocks the same type of calcium channels as some of our current medications, such as like verapamil, diltiazem, amlodipine, are calcium channel blockers for blood pressure. Even for Keppra, Lyrica, gabapentin, some of the use in seizure disorder. So when you have a medication that's doing the similar types of mechanism of action as the ones we currently use with less systemic side effects, this can pose to be a potentially therapeutic benefit. We find that we actually have 10 times more receptors of Cb1 receptors than we do have mu opioid receptors. That also brings the question to me of why have we not been using this for longer than the opioids have been using? If we have more receptors that are blocking pain reception and nociception, why was opioids used first, right? We do have a couple of examples of Cb1 receptors in practice right now. Nabilone, which is a synthetic THC, it is a full agonist at Cb1. So unlike THC is a partial agonist. It will bind to the receptor and come off the receptor as it modulates. Nabilone actually binds to the receptor at about almost 30 times stronger than THC. And this can tend to lead to a lot more side effects. A lot more patients find more drowsiness, euphoria, vertigo, dry mouth, adverse effects with Nabilone. And in Canada right now, it's mainly used as a induced nausea, vomiting, or for chronic pain or MS-related conditions. Next slide. We ended up having a Cb1 antagonist on the market back in 2006, but when we blocked our Cb1 receptors, we noticed that first of all, it does help reduce hunger, and that's why they marketed this as a weight loss agent. But when you disrupt the endocannabinoid system as a whole, you are disrupting many other physiological factors that go into play. And this is why we ended up with psychotic disorders. We ended up with more anxiety, depression, suicidal ideation, and this ended up getting removed from the market. Next slide, please. The next, we have Cb2 receptors. These are mainly found in the immune system, and this is where a lot of the function of the Cb2 receptor is to reduce inflammatory response, is to suppress the immune system. when during any type of injury or inflammatory condition, the Cb2 receptors are activated and expressed. So therefore, activation by like 2-AG or anandamide, THC, even CBD does activate in an indirect manner on Cb2. It can potentiate, it can reduce the effects of the cytokine formation, cell migration. Cb2 is also said to have some anti-tumor, anti-chemotherapeutic effects, which can reduce the migration of cancerous cells. So, I mean, that's preliminary evidence there, but I mean, there is a lot of hope in cannabinoids having chemotherapeutic effects. Next slide, please. We also have the Trpv1 receptor, and as pharmacists, we should know this one as the capsaicin receptor. This is a thermogenic receptor, and it is involved in pain signaling. It's involved in thermogenesis, but it can also be involved in motor behavior. So generally, the CBD actually specifically targets this receptor, and this is said to play a role in its analgesic effects. From there, we actually have a couple of the degrading enzymes. So just like how the monoamine oxidase inhibitors stop the breakdown of our catecholamines, we have fatty acid amide hydrogelase or monoacylglycerol lipase that will inhibit the breakdown or anandamide in 2-AG. So these are definitely therapeutic topics for future drug development, is to selectively target these degrading enzymes, thus increasing anandamide or 2-AG in our circulatory system. COX-2, we should all know this as Celebrex, right? Celebrex is a COX-2 inhibitor, and this is also involved in the degradation of anandamide. So when we inhibit COX-2, we're not only just having an anti-inflammatory effect by the Celebrex, but it also increases our anandamide tone and therefore can actually have more anti-inflammatory effects through the Cb1, Cb2 agonism. Next slide, please. So with that, I mean, in practice right now, we're generally talking about two main cannabinoids. This is THC and CBD, but please note that there are about 150 other cannabinoids. Some of them have not even been named yet or even discovered, but this is kind of goes to show the complexity of this plant and of this entourage of chemicals found in the plant. The THC, this is the most, the most abundant, the most famous. Everyone actually comes into my practice and says, I don't want the THC, I don't want to get high and loopy. But THC is therapeutic. It definitely has its place in therapy. And again, it's the way you use it, right? It's the same as opioids or Lyrica or any other medication. Just because if you're a cannabis naive patient or opioid naive patient, you're not going to go up to the highest dose. Well, in a recreational type of setting, most patients are looking for that THC dosing, right? They're looking for that high dose for those euphoric effects. THC is the most abundant phytocannabinoid found in the plant, and it is it's partial agonist at Cb1 and Cb2. It definitely has more affinity towards the central nervous system and Cb1 agonism, and this is where, learning this, you'll know what the therapeutic applications are. And it definitely is great for analgesia. It's great for spasticity. It's an antiemetic. It can be involved with appetite regulation. It's more of a sedative properties than your other cannabinoids. So therefore, it can help with seizure disorder and PTSD. When THC binds to that Cb1 receptor, it can inhibit the calcium influx and therefore reducing glutamate and reducing spasticity, reducing that neurotransmission. And especially in PTSD, this is where we see a lot of patients really going towards that THC component. Everyone also tells me I don't want THC. I don't need it. But to be very honest, you do. You do, even if it's a very small amount, even at 1 milligram, even less, there is a need for THC. Next is the CBD. CBD is getting a lot of fame now. It's the second most abundant phytocannabinoid. its mechanism is very much like we call it promiscuous. It's unknown because it has so many different mechanisms, and that's what makes it so complex, but also very potentially a very therapeutic agent for many different ailments. What on the slide there, we're seeing it's a negative allosteric modulator at Cb1. So I don't know if any of you've heard that when people have too much THC and they're, I guess they're too euphoric and they're too stoned, simply put, they end up using CBD. And with its mechanism of a negative allosteric modulator, that means it can actually change the shape of the Cb1 receptor, so THC does not bind to it, and therefore it can actually alleviate some of those negative aspects of THC. It's also a Cb1, Cb2 antagonist, again, antagonizing the receptor, so it's no binding to the site. It can actually act as an inverse agonist at Cb2, so this kind of plays into the anti-inflammatory effects, and this is one of the major reasons why most people are using CBD is for pain, inflammation. It's a Trpv1 agonist. It's also a 5-HT1A agonist, and this plays into the anti-anxiety effects of CBD. So there's a lot of uses, a lot of different mechanisms by way these molecules are working. CBD has been famed for its anti-epileptic therapeutic application. We've seen in the New England Journal of Medicine, the studies on CBD for Dravet and Lennox-Gastaut syndrome, which is a very pronounced seizure disorder. When patients were taking CBD at this rate, their seizures went from about 100 a day down to like 2 a day. So this is where kind of CBD started to explode, and now it's everywhere. I mean, in the United States, you're finding it in hamburgers and pillows, and it's getting pretty ridiculous, but there definitely is a valid therapeutic option for CBD and its use in medicine. And from where I'm sitting in a pharmacy community setting, we're starting to notice people and patients using less of their anti-inflammatories, their NSAIDs, because of the gastrointestinal side effects, and they're turning towards CBD in that sense. Again, the others are like CBN, CBG, CBC. A lot of these other cannabinoids will have potential therapeutic benefit as we start to learn more about them scientifically. Next slide, please. Stativex, I'm not sure if it's available in Poland, but this is one of the few cannabinoids that are readily available on the market, and it's produced by GW Pharmaceuticals out in the UK. This is a 1-to-1 oil in an ethanol base. So it's essentially CBD and THC equal ratio, and it is mixed into an ethanol extraction. So this is buccally absorbed. This was mainly used and FDA approved for chemo-induced nausea, vomiting, MS, and spasticity. Again, the cost of this is very inhibiting, and a lot of insurance companies are not covering this unless you qualify for an exemption. Next slide, please. Epidiolex, this has recently been approved on the FDA in the United States. It's not available in Canada yet. This is a purified CBD oil. I remember how I was talking about why you need THC. There are some studies out there finding that a full spectrum CBD oil, and by that I mean CBD with a little bit of THC, can actually reduce potential negative side effects. And what we're noticing in these Epidiolex trials of a purified, almost isolated CBD is that we're getting a lot more liver enzyme elevation. There's a lot more potentially side effects, reduced appetite, diarrhea, sedation. So again, and this could also be dose related, but we do have a couple studies that are showing the full spectrum benefit with very small doses of THC can actually lower the need for having a high dose that these patients are taking. A lot of these patients were doing up to 10 milligrams per kilogram per day. That's a really big dose, and at that point, it's almost unaffordable. And that's where a lot of patients are finding it's almost $1,500 a bottle in the US, which would last maybe a month, not even a month, depending on the dose that patients were using. Next slide, please. This is where, in the world of cannabis, this is where terpenes really fall into play. And when you're using an isolated product like that, such as Epidiolex, you are losing a little bit of what we call this entourage effect. Just like most patients using 10 or more medications, they are using an entourage of medications to treat a certain medical condition. This is what the plant has evolutionarily been grown for. It is for its entourage effect. As much as the pharmaceutical industry, as much as we want to, as pharmacists, to really isolate products, have a really well-defined mechanism and a well-defined outcomes, this plant is really showing us that maybe it's possible, maybe it's not, because this entourage effect is very important. And there is a lot of research going into this. And the terpenoids are really the essential oils that are found in it. It gives it the smell, it gives it the taste. This is why when you open up a certain cannabis strain, it may smell different from another one, and therefore may have different effects. Some of the listed terpenes are on the side there, and these are not just unique to cannabis. Everyone's had terpenes in their lives before. We find it in our cleaning supplies, we find it in our cosmetics, you find it in your fruits and vegetables and spices, and these compounds are, again, said to enhance the effects of the primary cannabinoids. Next slide, please. And again, coming down into the different strains of cannabis, this is where we're finding differences in the effects. So it's not just about, here's cannabis, go take it, you're gonna have the same response. It can be very different. Indicas are more of the drug factor. That's what they call, if you want to have a simple way to remember this, in the couch. That's a very common saying, but indicas are very much more sedating, they're more relaxing, whereas sativas are more uplifting. They're more like invigorating. It's like taking a coffee, essentially. What we're noticing now too, in the scientific world and in the analysis of all these chemovars, is that these two lineages, these two nomenclatures don't really make too much sense at this point, because these plants have been crossbred for so long that we don't actually have any true indica strains or any true sativa strains. They're generally a hybrid or a mixture of both of them. What my concern too right now is, well, that's good that we don't need to call them those things, but then we need to figure out what levels of terpenoids are making up this indica effect. What levels of, limonene and pinene and myrcene are giving it a sativa effect. So there's a lot to learn still, but right now where we stand and where most patients are comfortable with is these two terminologies. And this can play a factor into what type of strain to advise a patient to use. Next slide, please. So getting into kind of the absorption, distribution, metabolism, kind of the nitty-gritty things that we should be familiar with in terms of our pharmacology. There are various different ways to use cannabis. The most common way is inhalation. As a pharmacist, I do not recommend smoking. I think smoking, obviously, it does more harm than benefit, because you are combusting and you are putting a fire to a plant and inhaling that. Again, in our practice here at Hybrid Farm, we do not recommend that. We always recommend alternative harm reduction strategies such as vaporization. The reason for inhalation and the reason why it exists is very much for that rapid onset of effects. The onset is within 5 to 15 minutes, and it lasts anywhere between 2 to 4 hours, with a higher bioavailability, up to 55%, versus other methods of consumption. So there is a need for this. The patients that are having panic attacks, patients who are undergoing chemotherapy, are using inhalation for their medication. There's actually a couple of studies too discussing inhalation and the timing of cannabinoid ingestion when doing chemotherapy regimens, and it can actually help reduce the nausea, vomiting, and the ill effects that chemotherapy may bring on. So a lot of patients are ending up using inhalation about half an hour before they go into their chemotherapy session, as well as about half an hour after they have finished, and it can suppress their nausea, vomiting to a good degree that they have a better quality of life. Most patients, though, I'll tell you, sitting in my chair here, are not looking for inhalation, and if they are already been used to inhalation, they are actually wanting to get onto something more longer acting. And so most patients are going after the oils, the capsules, the edible type dosage forms. This is where, for me, this is more efficient in the sense that because it lasts up to 6 to 8 hours, the patient that's using this is not going outside every 2 hours and having a joint or having an inhalant type of dosage form. The long-acting effect is super efficient in the sense that they can dose it twice a day, and that's most of our patients are on a once, twice to 3 times a day regimen. The bioavailability is a lot lower, and it's a lot more erratic, and it's a lot more variable. It's about up to 20% bioavailable. So when you're thinking about this, when you're thinking about, well, how much THC and the conversion rates, I mean, you have to think about an average THC strain right now is about 15%. So if a person is smoking 1 gram of that, they're getting about 150 milligrams in an immediate dosage form release into their system when they're smoking. When you convert that into like a longer acting type of medication, you would want to divide that dose up throughout twice a day to 3 times a day. Generally, it's the long-acting effect. It is metabolized through the liver, and that's what gives it a longer pronounced effect. We also have topicals, transdermal patches, suppositories. These things are not currently on the regulated or legal market right now. Topicals are, but the transdermal patches, suppositories are not available. But topicals can be a very, very beneficial dosage form. The CBD is actually 10 times more permeable than THC, but there is a need for THC on the surface level. Our endocannabinoid system, again, it's abundant on the surface of the skin, and CBD can play into the anti-inflammatory effects as well as wound care and healing. And so a lot of patients are actually, I don't know if Voltaren is available in Poland, but here in Canada, a lot of people are kind of turning away from Voltaren or diclofenac topically and looking to switch to a CBD or THC topical to treat their surface ailments.
Yes, it is available.
These things are used.
Yeah.
Yep.
It is available in Poland, the Voltaren, Voltarol.
Okay, good, yeah.
Very popular as well.
Yeah. This is what, I start seeing this. A lot of people are going away from the traditional pharmaceuticals and starting to use cannabinoids as their therapy or their first-line therapy. And the reason why topicals, suppositories, transdermals, these may be more effective too, is because it bypasses that first pass effect. When you ingest it, when you eat it, or swallow a capsule, it does go through the liver, gets metabolized into the liver, and then the more potent metabolite, 11-hydroxy tetrahydrocannabinol, is the more potent metabolite. And that's what makes it long-acting. So when you're using it in a different dosage form, it can actually reduce that type of effect. And we do have a lot of patients actually using suppositories here. We did start doing in compounding in the early stages of hybrid farm. At this current moment, are unable to do that due to the legislation and regulation. But you will probably hear that a lot of patients are making their own suppositories out of cocoa butter or pretty much whatever they can find. And using this either vaginally or rectally, and there's a lot of therapeutic application for this. CBD, THCs, these are very fat-soluble drugs. They are highly lipophilic and highly protein-bound. So as pharmacists, when you see a volume distribution of like 10 liters per kilogram, I'm thinking right away, okay, well, if it's highly protein-bound, it means it might have potential interactions. CBD is almost 3 times the volume of distribution as THC, so therefore it can run into drug interactions. Next slide, please. And that's a major part of the education that patients are to receive going through a pharmacy, is knowing what medications they're currently using and if there are any substantial drug interactions. The primary mechanism by which they are metabolized, CBD and THC, is through 3A4, 2C9, 2C19. If you have trouble remembering that, just remember CC, 2C, cannabis, CC, 2C9, 2C19. Know that, remember that, because a lot of your medications are going through that type of metabolic pathway. What we're seeing in practice right now, a lot of co-administration of medications alongside with cannabinoids, a lot more pharmacodynamic interactions versus pharmacokinetic interactions. By pharmacodynamic, I'm talking about what the body does to what the drug does to the body, more of the synergistic effects of like anticholinergic or anti-CNS depressant effects. And that plays into your opioids, your benzodiazepines, more sedative properties, versus like the anticholinergics of, oxybutynin, your amitriptylines, your SSRIs, your TCAs, things like that may have more sedative, more tachycardia, more dry mouth, constipating, drying type of effects. The main type of drug interactions that have been documented, that have been studied, is clobazam. Clobazam actually gets metabolized through the 2C19 pathway, and we've noticed about a 200 to 500% increase in the metabolite of clobazam and clobazam. Therefore, if patients are concurrently using this, mainly your seizure patients, they would have to do a dose reduction of clobazam. We're also noticing a 3A4 inhibition, mainly warfarin. We're finding that does throw INRs off, and that can be potentially definitely a patient consultation, patient monitoring parameter, is to look out for increased bleeding. There are generally no major contraindications, but there are potentially a lot of medications that patients are using that could interact. What I'm seeing on a community-based side, as we'll talk later about just some practical considerations, patients are coming in for 3 main reasons: anxiety, pain, and sleep. Now, I'm sure you're thinking about a lot of those different drugs that are following along those type of patients, and you're right, it's the CNS, it's SSRIs, it's the benzos, it's your NSAIDs, it's potentially your opioids, your gabapentinoids. These are the ones that may have more synergistic sedative CNS depressant effects. Your anti-epileptics, these are the type of patient populations you need to have red flags go off when you see that, because of the and metabolism of your 3A4s or CYPs with your typical AEDs or your anti-epileptic drugs. It is excreted 65% through the liver and about 20% through the kidney. So your half-life, generally it's about 72 hours, about 3-day half-life. It is a fat-based drug. It does accumulate in your fat cells, and long-term use and chronic use can build up in your system and have a longer half-life. Next slide, please. So yeah, I kind of wrote this out as a kind of practical of what I'm generally seeing most and what kind of red flags are going on in my head when I'm counseling patients on cannabis. And it is the blood thinners, your anticoagulants, your Plavix, your Xareltos, your warfarins. Remember, like Plavix, for example, is a prodrug metabolized by 2C9. So CBD may inhibit this, and if it inhibits this, it may lessen its blood thinning capabilities and potentially lead to negative outcomes. So this is a very important monitoring parameter. Patients on antihypertensives, blood pressure medications, like we've seen through the mechanism of its, NPQ type channel calcium blockade, this can lower blood pressure, especially CBD. It can have a vasodilation effect and lower blood pressure. So I always counsel patients who are using this, monitor your blood pressure, especially in the beginning stages of your dosing schedules. Some of my patients have actually dropped their blood pressure about 10 to 15 points off their baseline and ended up having to reduce their blood pressure medications. Again, that's not the commonality, that's more of, the random case study, but again, important counseling points. I put antidepressants on there. It's mainly more of a theoretical interaction through their enzyme metabolism, the 2C19, 2C93A4. But what we're seeing is a lot of patients are having an easier time dose reducing your antidepressants. And as a compounding pharmacy, what we've done here is we've actually converted some of our patients' SSRIs, such as escitalopram and or venlafaxine, into a liquid formulation because these patients were having a very difficult time dropping dosage. As we know on the market, it goes in, from venlafaxine comes in a 75, a 150 type of dosage form. So their drops between those capsules was too much for them to handle. They were getting withdrawal effects, dizziness, nausea, brain zaps, to the point where they needed a little boost. And this is where they reached for a CBD to help kind of stabilize them and manage the anxiety. So that we are finding a lot of patients either having to dose reduce their antidepressants, SSRIs, or having to bridge them while they are coming off with a CBD. Down below there, anti-epileptic drugs, again, the clobazam via the 2C9 pathway can definitely increase the drug levels, and this is a very, very much well-documented drug interaction. Valproic acid, another common anti-epileptic, increasing your liver enzyme. So these are, some of the medications that you think of that are going through these type of pathways. Be cognizant of this is a monitoring parameter. And yeah, next slide, please. Some adverse effects of cannabinoids, and just in general, this isn't CBD specific, this isn't THC specific, but the adverse effects can generally be dosage form specific. And so if someone is inhaling or smoking, you may find more tachycardia, more postural hypertension. And this generally is more with a THC type dosing. In our GI system, there is a very not common, but very famous and we're seeing this a lot in the ERs and through the emergency departments, is cannabis hyperemesis syndrome. And this is a paradoxical type of reaction in which patients use cannabis, generally chronic high dose users are finding they get hyperemesis. And this is when they're vomiting excessively from cannabis use. The way to treat this and the way the patients are treating this, they're jumping in a hot shower or they're rubbing capsaicin all over their body. And this can actually help reduce the nausea, vomiting. And this is, I'm talking like projectile vomiting. I'm talking very will be the best form of medicating for this. But again, it's not very common, but I've had maybe one or two patients in the past couple of years that have indicated that they have been vomiting from their cannabis use. And it could be naive patients, it could be very experienced patients. Central nervous system, again, we know the effects of THC does have impairing abilities, drowsiness, dizziness, sensory impairment. Things might sound brighter or sound louder, taste better, things like that. That's euphoria that really comes along with the THC. And again, I think that is a dose-dependent effect. If you are using THC at a lower dosing, you should not be reaching these types of side effects. If you are using THC alongside with CBD, you should not be experiencing these side effects. That should be mitigating a lot of these side effects. The schizophrenia, paranoia, anxiety, for sure paranoia, anxiety can come out with high dose THC, especially in your cannabis naive patients. And again, I think if those patients that are using chronic high dose THC, they generally may experience anxiety over time. I'll give you an example. We have a lot of younger patients, 25, 35 years old, and they are very experienced users, but they are using THC only, and they're coming in because they're medicating for anxiety, they're medicating for depression, and there's a general knowledge or general practice out in the cannabis community world that the THC can help with anxiety, and that is true on some level. However, that is dose dependent, and if a long-term use of THC can actually exacerbate anxiety, it can be pro-anxiogenic. And this is where I counsel a lot of patients, like you need to switch your dose, you need to switch your dosage form, switch your strain, stop using just straight THC and do a more balanced strain. And so that these are these are types of counseling points and educational points that pharmacists can bring to the table. And then finally, like tolerance dependence that definitely can develop as with the mechanism, the receptor sites. The more you use, the more your receptors downregulate. Therefore, you need more to cause the same effect. It has been shown in studies that co-administration of CBD with THC can reduce this dependence tolerance potential. CBD alone does not have any tolerance or dependence side effects. Our body does not get used to it or essentially addicted to it, and a lot of patients do start and stop as they please. Next slide, please. So, yeah, practical considerations. This is kind of what I've been noticing throughout my practice in the past 2 to 3 years. Most patients are coming in for anxiety, pain, or sleep. Hands down, those are the three most common. The rest are very much smaller patient populations, seizure disorder, cancer therapy, but anxiety is probably hands down number one, and most patients are seeking out CBD for this. Patients are generally using 1 or 2 medications to treat their anxiety, depression, mood disorders, and they're either not finding symptom resolve or they are looking to use something more natural. Again, we're probably going to hear that more and more often with this. In terms of pain management, osteoarthritis, number one. It still kind of intrigues me that we're using Tylenol for an inflammatory condition when we know Tylenol has very little to minimal anti-inflammatory effects. Most of these patients do not want to use NSAIDs anymore because they have had gastric issues, bleeding disorders, ulcerations, GERD. So they are turning towards a CBD formulation to potentially treat their inflammation. And the list goes on and on. And knowing the mechanism, right? Going back to your mechanism, going back to your MOA of how these two components work. How does THC work? How does CBD work? That's where you will start to notice patterns in prescribing, patterns in using cannabis. Fibromyalgia patients, we should know this is a central nervous system disorder. This can be complex regional pain syndrome, right? It generally stems essentially. Patients want to only use CBD, but in my experience, they're going to need THC. And again, the THC dosing is not to be scared. And I do counsel patients a lot on this. A lot of them are very hesitant, very scared about cannabis because they think they're going to go jump off a bridge or they're going to go cuckoo because of the ongoing stigma that has been, it's been going on for the past 100 years about this. CBD is a very therapeutic, can be effective medication. It's the way you use it and how you use it. And with fibromyalgia and with these type of cancer-related pain and chronic pain, THC is 100% needed, and they will eventually need to go on there. That's why we start slow, start low, go slow. General mantra that's used in prescribing dosing. Most patients, you have to set expectations for them. Don't expect your pain to go from a 10 to a 0. I mean, I know we all want that magic pill that's going to make us, feel 20 again, but that's no such thing. And you have to lay that down right on the ground. And I do that almost every time we're talking about pain. Don't expect your pain to go away. Expect it to manage it better. Expect it to be more manageable. Maybe you're more mobile, so you're able to do more exercise and do more other entourage things. Eat better, exercise more. It's starting to come together. I always tell patients, take this with food. Food has actually increased the AUC and the absorption of the cannabinoids. I generally start with the CBD, especially in my cannabis naive patients. Generally start with the CBD, and then once they reach about anywhere between 40 to 50 milligrams twice a day without any symptoms resolving, then we start integrating THC. And we started at about a 2 milligram and increased by 1 milligram every so often. I would say every 3 to 5 days as tolerated. Some patients who have been using for a very, very, very long time, who are well experienced in the THC realm, are able to tolerate very high doses. I'm talking 40, 50, even 100 milligrams without any robust adverse effects. If you gave 100 milligrams to your grandma who's never had cannabis, she will hate you for the rest of your life. Don't do it. She might end up very anxious and paranoid and in the hospital. So next slide, please. So I kind of touched on this, but generally start with about a 10 milligram CBD dominant oil twice a day with a food or snack, and then they increase to about a 40 to 50 milligram BID. And again, if treatment goals are not being met, if their symptoms are not being resolved at that level, we generally introduce a THC at that point. Now, this is mainly for those three kind of scenarios I told you about: anxiety, pain, sleep. For the seizure disorder, is mainly a weight-based dosing, starting at 2 mg per kg. But that's a whole separate type of schematic, right? That's a whole separate type of disease state to treat. I think that you may encounter that 1 out of every, say, 20 patients. Mainly, you're going to be dealing with a lot of the chronic community ailments. For those patients that are experienced or have had some experience with THC, generally start around 40 milligrams CBD with a 5 milligram THC, and then increase that up to about a 40 milligram max of THC. Again, dosage form can also play a factor into this. Patients who have insomnia may require an inhalant form, right, to have that sleep latency, to reduce that sleep latency, get to sleep a little bit earlier. Taking the oil is not going to kick in for at least an hour to 2 hours. So having someone with insomnia waiting around for 2 hours is probably going to make them have more insomnia. But generally said, that's why they are using vaporizing forms. Next slide, please. What patients are saying when they're sitting down in my practice consulting, right off the bat, I don't want to get high. I don't want the fun stuff. I only want the medical stuff. Very, very common, and it's a very common, I guess, anxiety or fear that they are going to have some sort of negative outcome. A lot of patients may have tried this back in their teenage years, their college years, and had an experience, they didn't like it, and now they're coming back to it because they've read about it on the internet. Dr. Google has told them that CBD is great or THC is great, and they're looking for your advice. A lot of them are asking if this can be taken with your medications, and this is why it's important to know your drug interactions. It's important to know your dosages, your onsets, your different therapeutic options, your mechanism of action. This is what's going to guide you in your decision making. In Canada, I'll tell you right now that pharmacists are not allowed to widely distribute cannabis. We are an exception because we applied for the license, but this has gone recreational at storefront level before it has gone to pharmacy level. And so what we're seeing now, I'm seeing this almost on a daily basis, at least 2 to 3 times per day. A patient is calling me or walking into the pharmacy and saying, I bought this at a dispensary, they told me to buy this, and then I took it and I had a bad reaction. What am I supposed to do? How am I supposed to use this? How do I take it? So again, that's where we, sit down with them, we consult with them, and really just kind of walk them step by step of what they're trying to treat, how they're trying to treat it, and kind of go down the prescription path with them. A lot of them say they want to get off their pharmaceuticals. They don't trust pharmaceuticals. They want something more natural. So again, when patients really present like this, you have to set it comes slowly, and that's part of your advisory, that's part of your clinical services, that's part of your relationship with the patient is potential deprescribing. What I tell patients mostly too is who are very apprehensive of taking CBD, I generally say you don't notice when you take CBD, you notice when you don't. And what I mean by that is it's a very subtle and mild type of medication. So a couple case studies here. I just want to really briefly go over a couple of this really quickly. Mr. S, he's a 21-year-old male, presents with cannabis use disorder, a mild use disorder. He generally has mood swings, anxiety, agitation. He has been self-medicating with cannabis, using joints or bongs, smoking about 1 to 2 grams per day, and he is actively seeking out advice and help from the medical side, my side, the pharmacy side, to kind of reduce his intake and reduce his need for using THC on an ongoing basis. His mother reached out to us. He's very concerned about his habitual use. The patient is definitely interested in reducing his cannabis. I wanted to present this to you guys because I'm getting this more and more and more. And I think this is what separates the medical side versus the recreational side. And this is what I need to show this to our College of Pharmacy and our national, our legislation is who's looking out for these patients, right? You're going to get this a lot. Patients want to come off or want to reduce. They want to reduce their smoking. And there is a stepwise approach to doing this. This is the same. You treat this the same as smoking cessation. You can't just tell someone, okay, quit smoking, stop it right now. That's not going to happen. Instead of having that type of approach, it's more of a let's switch your strain approach. Switch from a THC percent to a balanced strain. Start integrating more CBD into there. And then you can switch from a smoking to a vaporizer or a vape pen, or from there you go down to an oil. From there you go down to abstinence. And so there is kind of a stepwise approach that we are helping patients utilize this, and it's very it's honestly very rewarding. And we might start seeing this more and more as the globe starts getting more legalized and more recreational adult use cannabis is coming to the forefront. Next slide, please. Autism spectrum disorder. This is very common. We are actually helping with Regis over at CHIO to study the effects of cannabinoids in autism spectrum disorder. So we have patients under the age of 17 utilizing CBD to help control their behavioral symptoms. A lot of the parents have either tried stimulants or tried the antidepressants, and some other parents are completely against going down that route first. So they wanted to go to CBD, such as our case study here, SG. He's an 11-year-old boy, was very disruptive in school, difficulty sleeping. Teachers were having a hard time for him focusing, concentrating. Essentially, his parents described him, he was off the walls. When they came in here, they tried almost everything. They tried to reach out to their doctors. They tried to go to clinics. Nobody was going to help them. And we started to initiate a protocol with CBD. They ended up starting on a very low dose, about 15 milligrams twice a day, ended up titrating upwards to about 25 milligrams 3 times a day. After about, let's say about a month to 2 months, the patient's parents and the patient came back and they were literally crying in my pharmacy because of how effective this was on their life. And the parents pretty much got their life back. They were less stressed, they were less anxious. The patient was sleeping better. He was behaving well in school. So it's very again very rewarding to see this type of medication being used in appropriate manner to help treat these type of patients. Next slide, please.
So we have questions. We came to the question form. A second. Just trying to stop sharing.
That's it.
Yeah. Okay, we are here. Okay. So I hope you all like it, but before we all finish today, I would like to ask a few questions. Rahim, you said that you are doing your own practice. So what does it mean? That you just see your patients yourself? Do you have your own place like a doctor?
So we're sitting in my consultation room right now. It's my own pharmacy practice. So pharmacists are not allowed to prescribe or dispense cannabis. So we do work with doctors, medical doctors, who are authorizing the use of medical cannabis for medical purposes. And then we are the ones consulting the patient on their therapeutic options, as well as dosing, as well as drug interactions. So we really work with the patient really closely on, introduction of cannabinoids, as well as titration and escalation.
Excellent. And is your practice contracted with the sort of like a national health fund or like a government, or how does it work?
We are an independent pharmacy that we're one of the few or one of the only independents in the country that applied with the government of Canada, Health Canada, to get a license for medical cannabis.
Wow, that's very interesting. That's very interesting because we are considering in Poland also for pharmacists to have independent practices, and I'm just thinking how it is regulated over there and what's the money flow. And who is paying for the services. So this is very, very cool. We have a few more questions. Is there any project regarding marijuana treatment for people with Parkinson and atrial fibrillation?
Parkinson's and which?
And atrial fibrillation, AF.
Parkinson's, yes. I mean, there's a lot of the mechanism with Parkinson's, right? It's a lot of that glutamate excitotoxicity, and they're causing central tremors, causing, gait and mobility impairment. THC acts as a relaxant, anticonvulsant, antispasmodic. So a lot of these patients end up starting on CBD, but transition towards a THC dosing. Generally, we've seen an improvement with it. It's slight, moderate improvements, but there is definitely lots of research going into the use of cannabinoids in Parkinson's. So again, I feel like there's a lot of patients are fit right here. It's in that middle range where cannabinoids are doing something. It's great. It's helping them, and on an average level. The top 10 up here, this is a game changer. This is absolutely, I can't believe this has been illegal. This has worked so well. I'm doing so much better. It's night and day. And then the bottom half down here is about 10-15%. This doesn't work for me. This is expensive. I don't see the need to purchase this because it's not really helping me. I'm going to stop. And that's where we're kind of seeing things right now.
We have another question about Parkinson and atrial fibrillation patient, and you mentioned something about using the inhalation, the smoke. And is the smoke dangerous for this patients? Can it be dangerous?
Generally, yes. Generally, it can be because of the rapid inhalation and the rapid ingestion of cannabinoids such as THC. It can cause tachycardia. It can cause negative dilatory effects on your circulatory system. So patients with AFib, I would highly recommend do not smoke. I would switch to a oral dosage form, higher in CBD versus THC, to reduce that tachycardia, vasodilation, lower blood pressure.
So this form definitely is not.
What's that?
This form is not recommended, the smoke form for patients with atrial fibrillation and cardiovascular diseases, basically.
Generally not, no.
Okay.
Generally not, especially if it's very unstable angina, unstable cardiac conditions. I would stay away from inhalation.
We have one more question. Is CBD directly linked to the weight loss?
No, actually, it's so generally CBD does not increase appetite. It can reduce appetite, if anything. Again, it's very mild, and I've only had a very few reports of that. But there's actually a cannabinoid called THCV, which is the cannabivarin, actually has appetite suppressant abilities. So that's where you're probably going to see more research going down that path, especially for diabetics and those patients that are concerned with weight gain. Yeah.
And we have the last question. Are there any benefits for people with dementia, especially anxiety occurs with dementia?
Yes, absolutely. We actually have a lot of patients, 75 plus in retirement homes, nursing homes, using CBD specifically for behavioral symptoms of dementia. Because of its anti-inflammatory effects and its Cb2 agonism effects in your immune system, it can actually and there is a couple studies on this, mainly in rat and animal studies, but it can actually break up the amyloid plaques. But what we're using this as a behavioral modification type of medication, and a lot of our patients are doing a lot better than Seroquel and benzodiazepines because that age population, I mean, it's on the beers list. It's dangerous. They can have more falls, more adverse effects. They are using CBD and it's controlling a lot of their agitation, a lot of their sundown effect. So yeah, very, very, very important patient population to consider.
Excellent. There's one more last question about using permanently the cannabis. Should the patient have breaks on using cannabis, or the patient can take it all the time?
Generally, I would say, I mean, breaks is important, especially if they're using high dose THC. You do want to give your system that time to replenish your cannabinoid receptors. But right now, there's no length of how long should I take this for. Generally, it's until symptoms are resolved, and then you can start using it as needed. It's a long-acting medication, right? It's 72-hour half-life. If you start forgetting to take your medication, that's a very good sign. That means you don't need it as often. You start using it as needed. A lot of our patients start on a regular dosing regimen for about 1 to 3 months, and then eventually they start tapering, and they just start using when needed. Like chronic pain, again, it's risk versus benefit at that point. Most of them are using it on a regular basis. I don't think chronic high-dose THC should be done with that. I think they should be used concurrently with CBD because, again, we reduce that tolerance dependence to the actual medication. So,
wow, that was extremely lots of knowledge, and we see very positive comments. So thank you very much for having us here. Thank you, Rahim, for this.
Thank you.
Unbelievable. I think like everybody can confirm that Poland has never seen such a piece of knowledge about cannabis so far. So thank you very much. It was just 1 hour and a few minutes, so the time flies when we are having fun. So thank you very much to you and for your time. It was really great. And thank you to the PSF, Pharmacists Without Borders Canada as well. Thank you to Dr. Weilacourt and all the people from CHIO who are supporting this events basically in Poland. So thank you very much one more time, and hopefully to see you in a week time.
Thank you for having me. Thank you for listening.
It was great. Thank you so much, Rahim. Thank you so much.
Appreciate it.
Thank you.